Good evening, doctor. Myself, Mahesh, GM from Fourts India. Let us welcome you for the fourth edition of our webinar for trace supportive treatment options for diabetics. Today, we have a interesting personality, Dr. K.N. Manohar. Doctor is a very good academician, also a clinician. Doctor has started his education from 99 and he has been still learning so many things and still continuously learning many things, because he, by seeing his CV, I think he has not stopped after that. So he's on the process and he completed MD, DNB and triple FRCP and so on, many things. The doctor is a clinical examiner for MRCP, also a organizing secretary in Karnataka State RSSDI, and conducted APCon, also a faculty for the DNB medicine. So this is on the academic side, and to say the award-winning moment, so doctor has received an award for the excellence in diabetes care through RSSDI 2018. The best known award, the Kempe Gowda Award, the highest civilian award for Bangalore. So that also won by Dr. K.N. Manohar, and Rising Star in Diabetology and the Diabetes Awareness Initiative and Investigator of the Year Award. So many awards, and his mission is that Swasth Bharat. So healthy India is his mission. So he is also working towards that in so many different forums. And this is one side, academic as well as clinical side. And when it comes to the third one of the sports personality, he is a continuous marathon runner. So I have also checked in the website, he wore a t-shirt of 25851. That is a number with where he has finished. And so very interesting person, and also given so many lectures and taken part into many camps, activities, and contributed many textbook chapters and journals, also write up in various dailies, newspapers, television, audio, so many. So within 5 minutes, I can understand that just doctor has opened this video, I can see that how busy he is. So first of all, thank you very much, sir, for allocating your time for us and for the benefit of all the clinical persons. And so we welcome you, sir, for this webinar, and we are expecting more from you, sir.
Thank you, Mr. Mahesh, for this wonderful introduction. Yeah, sometimes some people ask me, how do you manage time? So sometimes I say that busy man has time for everyone. Anyway, thanks, Fourts, for the opportunity, and I would like to thank people who have been logging in. Yeah, it's webinitis is the new syndrome after COVID-19. Like every day, there are so many talks, and people still wanting to listen to us is a great thing to know. More importantly, this topic is totally different from what we talk. We always talk about diabetes, hypertension, dyslipidemia, and even when we talk about COVID, we sometimes we engage in how it comes, what it does, and things like that. Even the treatment is more like a guidelines given by the government and so on. I don't know why it's not moving. Yeah. So supportive treatment options in the COVID-19, very interesting, and I was just reading through it. I'm in the thick of things from the start of this pandemic, and I think I was one of the first person to be quarantined in our hospital, because I had exposed to the patient number 21 in the country. So tough times, and then of course we have come a long way now, and I'm in the forefront from then, and then we keep doing COVID duties also. Many times I didn't find time. I was wondering how ivermectin will help, how doxycycline can help, how hydroxychloroquine help, how zinc, calcium, vitamin C, vitamin D. We talk very few words about the other parameters and a bit more about the zinc and the respiratory tract infection. Especially in the perspective of this COVID-19. Good or bad, I don't know, zinc is not stored in the body. So once if you think something is not stored in the body, it has to be continuously supplemented. And also it is seen that excess intake results in reduced absorption and increased excretion. What it tells is the body knows that this element is not always good. So if excess of it also can cause problems. For example, iron. If you're treating iron deficiency anemia, now latest guidelines says Even if we give it alternate day, 1 dose is good enough. You don't have to give 2-3 times a day, because it may not be useful or it may be harmful. That's why the body throws out excess iron. Similarly, zinc also, if you take more, it is thrown out. So zinc is required for the biological function of more than 300 enzymes. Zinc is considered crucial for immune responses. And that's why almost all of the guidelines worldwide, including the ICMR and a lot of state guidelines and even multiple hospital guidelines, we include zinc in the treatment. Zinc influences and interacts specifically with components of the immune system. Briefly, we'll see what they are. So it may be useful in reducing infection relapse and in restoring immunity. It may perhaps have some properties with respect to aging and preventing age-related degenerative disease. The efficacy of the zinc is not only related to the dose, but also the length of treatment. So when we write these supplements, please do not write for years together. You know, there are a lot of the patients who with chronic disease like diabetes, hypertension, they may forget those important tablets, but they will never miss the multivitamins what they are given. So that is an important thing we need to emphasize. Maybe especially when you're looking at zinc, nobody knows the exact duration, how much to give. Better not to give for long duration and be kept during peri-infection is what I would suggest, recommend. I don't know if Fourts people are happy about my recommendation, but that is where the science says. So zinc supplements are not for long term. It may do more harm than good. So as a preventive and adjuvant therapy, yes, how does it help? Clearly, it improves mucociliary clearance, inhibits replications of SARS-CoV-2 by the ACE mechanism, which I'll come to it later. It modulates antiviral immunity. It also limits excessive inflammatory response. It inhibits bacterial co-infection. It has some effect on the bacterial co-infections also. So directly from, it prevents the SARS-CoV-2, which is a bone of contention nowadays. By improving mucociliary clearance, it washes off from the respiratory tract more easily. And if something is left behind, it also has some properties where it inhibits the binding of the ACE receptor and inhibits replication. And it also has a role as an anti-inflammatory, not only in the viral, but also antibacterial action. This is an important thing what we need to remember. Why? Because COVID-19, we all know, binds to the ACE2 receptor gene and impairs mucociliary clearance and predispose lung for further viral and bacterial aggression. So by working on the mucociliary clearance, if you can look at this slide on towards left, it shows these are the mucociliary of the respiratory alveoli and cilia morphology. So it improves the ciliary beat frequency, and it also helps in the barrier function of the cells, and it helps in clearance. It significantly improves mucociliary clearance and increases barrier function, thereby hopefully arrest to whatever little extent the COVID related issues in the pathogenesis of COVID-19 infection. More importantly, by binding to the ACE2 gene, if you can look at onto the left of your screen, it has two important functions. One is decreasing the activity of ACE2 receptors on SARS-CoV-2, and also inhibits RDRP, RNA-dependent RNA polymerase. This is the enzyme. We all know that SARS-CoV is an RNA virus, and it has to multiply using this RNA-dependent RNA polymerase. Thereby, if you look at the lower part of your screen, because of the transcription and later translation is when RNA becomes DNA, then the virus can multiply on its own. So for the benefit, if you want to revisit the RNA DNA virus onto the left, one virus is seen. It binds to the ACE2 gene. That gets internalized and it removes the viral RNA like this. There is an enzyme. Before the RNA is of not much use for multiplication, it has to have a DNA. The process of converting RNA to DNA is called translation. See, after translation, how this virus is multiplied into three 3 viruses, just for schematic representation. But before it goes into becomes a DNA, the RNA also has to multiply to a threshold number. For this multiplication, it requires RNA dependent RNA polymerase, which multiplies the monomers to polymers. So multiple viral templates are formed. So it has activity on two things, is to receptors and also RD-RP enzyme. So it also modulates antiviral immunity by upregulation of interferon alpha production, and also it upregulates antiviral proteins which help to degrade viral RNA and inhibits translation. So if you can look at again, interferon alpha is a very important thing which promotes immunity or builds up the immunity, and that's how it improves it. And it also, another problem what we see in SARS-CoV is not just the inflammatory response, but excess or ill-targeted inflammatory response. That's another important entity where zinc comes into the play, where there is a lot of inflammation, and if it is misguided or if it is overwhelming, it can drive it into a cytokine storm. So it offers anti-inflammatory activity through inhibition of NFK beta signaling pathway and down-regulates the pro-inflammatory cytokine production so that the risk of cytokine storm is stalled there. So it inhibits the binding, multiplication, it is pro-immune boosting, and also prevents cytokine storm by down-regulating the inflammatory cytokine. So in all three mechanisms, it helps for the antivirus per se. But how does it help the bacterial? So many times what happens, the virus comes, does damage and goes, and then the bacteria takes over. So inhibits bacterial co-infection by Streptococcus pneumonia. So that is because of this bacterial homeostasis is affected by this. So it makes the milieu not very good for the Streptococcus pneumonia to proliferate. So we know that Streptococcus pneumonia infection is a very common co-infection with respect to the SARS-CoV-2 infection or any influenza like viral infection. That's why this has an antibacterial property. I'm not saying it's a potent antibacterial and you don't have to use any antibiotics, nor am I going to say that this is the time of the season or the year where we need to promote influenza viral vaccines and more importantly pneumococcal vaccines also. So the risk factors of zinc deficiency and COVID mortality are same. This is another important thing which I would like to draw your attention to. Like if you know, we all know that what are the comorbidities on which the mortality are increased with respect to COVID-19 infection. The single most important thing is age. Advancing age, especially it starts after 12 years and beyond 60-65 years, the mortality rates are high. And also with diabetes, obesity, people with atherosclerotic cardiovascular disease, these people are the one who has high mortality. Not only that, these are the same group of people who have zinc deficiency also. So possibly there is just a association or a causal relation. I'm not putting forward that hypothesis because about this disease, we hardly know anything, but these are the same group of people who have a high risk of COVID mortality, pneumonia, ARDS, and also ventilator-induced injury, including VAP, the ventilator-associated pneumonias. So zinc deficiency has the similar comorbidities as people who have these worsening of outcomes, and zinc supplementation could be very useful. So in a nutshell, about whatever I spoke till now, the risk factors on the right, what I'm showing are the people who have more prone for zinc deficiency. These are the same group of people who have risk for getting COVID-19 severe infection because of the problems of pneumonia, ARDS. How does zinc help it? On to left, you can look at, as I said initially, it improves mucociliary clearance. It improves the barrier function so that the virus doesn't bind via the ACE2 receptor, and it reduces the activity of RD-RP so that the multiplication doesn't happen, so that virus doesn't become DNA and multiply. And it has an anti-inflammatory action by NFK beta, and also it reduces the cytokine storm by inhibiting the pro-inflammatory cytokines which are deleterious. Not only that, it improves antiviral immunity and also Streptococcus pneumoniae co-infection is reduced by using zinc. So in a nutshell, if you want to take home message from me with respect to only zinc, this is the slide which you can take a screenshot and keep. What if too much of anything is bad, isn't it? So the one word of caution what I would like to say here, because just because it is a company talk doesn't mean we need to talk only good about it. I always talk science more than promotions. That's how it should be. Prolonged intake of zinc supplements ranging from 50 milligram up to 300 milligram. It is also associated with leukopenia, neutropenia, sideroblastic anemia, decreased concentration of the other trace metal like copper, decreased activity of copper containing enzymes, and altered lipoprotein metabolism and impaired immune function. So underline the last part of it. We are giving zinc to improve immunity, and if we overdo it, it impairs immunity. But if you ask me how much to give for how long, I couldn't find any evidence on how long should be the duration. What I traditionally do is initially acute treatment I give, and I follow it up for a month or two and then stop the zinc supplementation unless there is some deficiency status persisting. Why concentrate only on the zinc? How about vitamin D and COVID-19? I think one of the most consistent vitamins which are associated with immune deficiency and which have proven, a lot of papers nowadays we are seeing, is vitamin D among all the vitamins, and of course some evidence for vitamin C also, but most consistent findings are with vitamin D. And I don't know, we are linking from cold to cancer, anything to vitamin D. So principal function is anti-proliferative and anti-inflammatory, anti-fibrotic effect on the lung tissue. It inhibits aromatase enzyme and preventing role in developing autoimmune disease. It has immunomodulatory role on the innate and also the adaptive immune system. Another important factor which people have noted is cytokine storm also can be, to an extent, at least theoretically, reduced by the supplementation of vitamin D, as it has some interaction on DPP4-CD26 receptor. So this is actually one of the hypotheses initially was floated that DPP4 inhibitors could be very useful in SARS-CoV-2, but later we have learned that DPP4-CD26 receptor was more useful in MERS or Middle East Respiratory Syncytial Virus or SARS-CoV-1 virus. So not so much of an interaction with SARS-CoV-2 virus, wherein the ACE2 gene is more implicated in the pathogenesis for SARS-CoV-2 as opposed to SARS-CoV-1. And of course, the other receptors like retinoid receptor, vitamin D response elements are the places where possible interaction of vitamin D can change it. Again, in a nutshell, if you want to look at it, it improves immunity. It reduces adipose tissue inflammation, vitamin D I'm talking about, and it also reduces lung fibrosis in the long run, and it possibly has an activity on the enzyme aromatase. And some evidence are pointing towards by interacting with CD26 receptor, as I said, it is much more for SARS-CoV-1 rather than SARS-CoV-2. So there are some theories where it translation again gets inhibited and possibly reduces the cytokine storm also. So how about vitamin C? Again, we all knew that vitamin C helps also in regulation of ACE2 and modulation of the renin-angiotensin system. That's why initially a lot of concerns were there by use of ACE inhibitor and ARB. Will it be detrimental? Should we stop it? But later now, all bodies have come forward and said that ACE group of medications can be continued. And it also again has some role in cytokine storm and oxidative stress. And also vitamin C is known to boost immunity and avoid hyperimmune reactions. Immune system is a group of cells which fight against infection, but they can have an improper response and cause cytokine storm. So this inflammatory response syndrome is also arrested, and also it inhibits hyperactivation of the immune system. So there should be a balance between the pro-inflammatory and the anti-inflammatory component. Whichever way you swing more, it becomes more detrimental. So in a nutshell, again, if you want to look at how vitamin C helps, these are all the mechanism. Again, to an extent, some activity on the spike protein, they say, and then a lot of places where RNA replication and then release of the virus also is inhibited, is what they say. Again, none of these things are 100% proven. We know by systematic mechanism past how vitamin C works, and we extrapolate it. Unfortunately, even till today, we do not have any drug which is specifically we can 100% say that it works. So then we also know, I was just wondering, like we use doxycycline, hydroxychloroquine, ivermectin, and even azithromycin, even in case of SARS-CoV, when we say it is a viral and we give it early. If you are giving it at least an antibiotic slightly later, we can also justify that possibly secondary bacterial infections are targeted. So what is the use of giving this? So I was doing some homework on this. So this is what I found out. Even though we think these drugs have other responses, like hydroxychloroquine is an immune modulator, doxycycline is an antibiotic broad spectrum, and ivermectin is anti-parasitic, but they have some other effects on inflammation. May not be as good as a steroid like effect. Even in the same breath, I can talk about Montelukast also. Some people say fexofenadine is useful, some say famotidine is useful. You name a drug which has not been tried or postulated, we can hardly find anything, even fenofibrate for that matter. So doxycycline, they say it has antiviral against dengue, and it has some anti-typhus and anti-parasitic property, but it's not a sole agent to be used in that way, but some minor mechanistic action could be there. It inhibits post-infectious replication, reducing ability of virus to enter the host cells. It down-regulates NFK beta, which again, zinc also works in the same pathway, so possibly they have an additive effect there. And also it reduces inflammatory cytokines like TNF alpha, interleukin 1 beta, and the most dreaded interleukin 6. So this is how doxycycline helps. So how does it help? It is an antibacterial. Yes, it has some antiviral property. It inhibits post-infectious replication of the virus. It down-regulates NFK beta and reduces inflammatory response, including the IL-6. Hydroxychloroquine was very, very interesting mechanism of action. I think most of us used prophylactic therapy initially. Some of us have discontinued. Some of us are continuing to use. My take on it is, I don't know harm in taking once a week. Should not be a problem. Hydroxychloroquine, we all know it is a weak base. So it makes the pH towards basic from acidic. And they say the viral binding and replication in a basic pH is less easier. So it makes the virus not to bind to the receptor, and it reduces its multiplication. So this is the postulated mechanism how possibly hydroxychloroquine can help. Besides, it also inhibits several enzymes, and it inhibits viral glycosylation, and most importantly, we all know it is an anti-inflammatory, beautiful molecule we've been using for so many arthritis and connective tissue disorder. So hopefully it is helpful. We are using it either a doxycycline, ivermectin combination, or hydroxyazithromycin combination. Some care has to be taken when you use hydroxychloroquine azithromycin combination when you treat cardiac patients. Ivermectin, it also inhibits alpha-beta 1 mediated transport of viral protein in and out of the nucleus, because entering the nucleus is very important for the virus, because thereby it starts multiplying, because virus, as we all know, is an RNA virus. It doesn't have a DNA. It gets access into someone's DNA, and then it starts multiplying, and it causes damage on its own, or by triggering the immune response. So this is how the pathogenesis it is. So before I close, I thought this is my experience so far, the 10 commandments, as I call it, as the golden rule. I'm sure all of you know, masking, distancing are the vaccine equivalents. Continue to do that. For checking spread of, it's prudent to treat all fevers as COVID-19 communicable disease and institute isolation. Do not waste time by if they are improving, then it is fine. Otherwise, always all fevers, cold and coughs are COVID-19 unless put otherwise. Loss of taste and smell are the symptom equivalent of RT-PCR. Not only that, people who have this loss of taste and smell also do very well. And who is a primary contact? If someone asks me, just now another doctor had called me before I started that he got into contact with a friend of his who is tested positive. He's also a doctor. Yesterday he was ringing me in the night. So this doctor is worried. At least by definition, if you want to know what is primary contact, if you are in reach of a patient within 6 feet distance and for more than 15 minutes, it is called as a primary contact. RT-PCR is a gold standard, yes, but HRCT also is equally useful when you are in doubt, and also to grade the severity, mild, moderate, severe by the CT scoring, and also to look at the two things I would like to say. One is the CORAD scoring, where CORAD scoring says what is the likelihood of that CT scan being COVID. If CORAD is 4, 5, or 6, it is much more to be COVID. 1, 2, or 3 is less likely to be COVID. CORAD 6 is definite COVID. It doesn't say severity. Severity, another scoring is there. Less than 9 is mild. More than 15 is moderate, severe. 9 to 15 is moderate. And to assess the severity, please look at the symptoms of fever, cough, and dyspnea or saturation. And rising CRP, ferritin, D-dimer, and interleukin-6 are the markers to watch out for. But first, you should go clinically and then only look at these markers, because there are a lot of false positives which we are seeing. Zinc, vitamin C, and D are the supplements which we need to use. And timing of initiating steroids, heparin, and remdesivir are critical for outcome, even though the 2 large trials of remdesivir have said might not be much of use, but definitely it is useful, and its utility is based on the timing when you give it rather than anything else. Another important thing is happy hypoxia. People who are hypoxic but still look fine. So that is the most important thing we need to watch out for, and check the pulse oximeter. Of course, first make sure the pulse oximeter is all right. Next is day 5 to 11. From the start of the symptoms are the days to watch for. If someone is improving, they'll be all right. But if they are worsening fever, cough, or breathlessness, watch out. They are the one who is going to deteriorate. An isolation period, how long the patient should be isolated? At least 17 days from the start of symptom, not from the diagnosis, from the start of symptom. And if someone do not have any comorbidities and symptoms are mild, please manage them at home itself. Please do not admit everyone. And as I say, the last point, the 10th commandment is mortality rises with age, and it starts about 12 years. Even though some cases of neonatal and childhood mortality is seen, but it is very, very less likely, and it worsens after 65 years. And presence of comorbidities like diabetes, hypertension, heart, and kidney disease are important for it. I hope it was informative, and if there are any questions, I would be glad to take them up. Thank you so much, and thank you, Fourts, for giving me the opportunity. And thank you, everyone, for joining in for this session.
Yeah. Thank you very much, sir, for the interesting session. Let me check for the... Sir, one thing is that for the post-COVID patient, is there any care is separately available that...
Yeah, just about, we had a discussion, a Manipal meeting, that there are a lot of patients who are having problems, from simple problems like tiredness, aches and pains, to sleeplessness, to complex problem like I had seen a case of transverse myelitis, a case seen of pancreatitis, and there are few cases, people who are hypoxic. Their oxygen is not improving. I have about 2 cases like that. So we are working on how best we can do good to them. Well, if you're looking at your perspective, yeah, zinc supplementation up to 2 to 3 months should be all right. But the other things need to be looked out. And for the oxygen, yeah, it's become a challenge now. One lady, she's quite elderly. She's requiring oxygen for more than 20 days now. Even though after complete recovery, more than 20 days, just now they had message that oxygen, when they take it out, it is coming to 68. And 1 liter itself is making it come normal. She was on a tapering steroid. She was on heparin. We are planning to do a PFT, but I don't know how much it will help, and a CT scan to take it further.
Okay. So thank you very much, sir, for sparing time for us for the webinar, sir.
Thank you.